The year is 1914. A soldier is lying in a field in France and the wound in his leg has been open for 4 days. It smells. It moves. When the stretcher bearer finally reaches him and cuts away the field dressing, he does not see clean red tissue underneath. He sees larvae, white, grain-sized, working through the flesh in slow, methodical rows. The bearer's first instinct is to remove them. He doesn't, and the soldier keeps his leg. That is not a metaphor. That is not folklore dressed up as history. That is the thing this is about. Because here is the paradox that runs through 2,000 years of medicine and still sounds wrong the first time you hear it. A wound with larvae crawling through it could mean a better chance of survival than a wound that looked clean. Not always, not under every condition, but enough times, in enough places, across enough centuries that the pattern became impossible to ignore for anyone who actually spent time watching wounds instead of just dressing them. The first recorded observers who noticed this were not European. The ancient Maya used larvae therapeutically. Aboriginal Australians used them. Chinese military physicians noted the effect in texts that predate the Common Era. None of them had a theory about bacteria. None of them needed one. What they had was repeated observation of the same thing across different bodies and different climates. A wound touched by fly larvae, left to run its course, often stopped rotting before a wound that was scraped and dressed and sealed away from the air. You need to understand what a wound looked like before antisepsis before you can understand why this mattered. Gangrene in the pre-antibiotic world did not announce itself slowly. It moved. You could watch it move across a limb over the course of a day. The flesh went from pink to pale to the color of old bruising and then to something darker, something that no longer looked like flesh at all. The smell was specific enough that experienced surgeons could identify necrosis before they crossed the room. Sweet. Wrong in a way that sits at the back of the throat. The tissue under it was liquid. The tissue around it was going the same way. There was no stopping it once it took hold except by removing the part it lived in. Amputation or death. Those were the ordinary options, so any method that slowed the spread of rot, any method at all, carried real weight. This is the frame you need. Not disgust, not morbid curiosity. The frame is, what else was there? Because the surgeons who tolerated larvae in wounds were not being careless. They were watching outcomes. The battlefield context made repeated observation almost unavoidable. Wounded men were left in fields. Flies reached them before surgeons did. By the time a doctor arrived, hours or days later, some wounds were already colonized. The surgeons who kept records, and some of them did, noticed that certain of these colonized wounds were doing something unexpected. The dead tissue was being consumed. The living tissue, the pink bleeding tissue with intact blood supply, was largely not. The larvae appeared to be selecting, not consciously, but the effect was selection all the same. Ambroise Paré, the French surgeon working in the mid-1500s, documented wounds in military campaigns that modern readers have interpreted as early accidental myiasis observations, fly larvae growing in human wounds, with outcomes that surprised him. He did not draw conclusions about mechanism, but he wrote down what he saw. That habit of writing down what he saw without fully understanding it is exactly how useful information survived long enough for someone else to test it later. By the American Civil War, the pattern had sharpened into something closer to deliberate. Confederate surgeon Joseph Jones documented cases from field hospitals where maggot colonized wounds showed lower rates of secondary infection and tissue death than comparable wounds treated by conventional cleaning. He was not endorsing the practice. He was recording it with the same cold attention a good field surgeon gives to anything that happens more than once. So ask yourself the question that sits underneath all of this. Were the physicians who allowed larvae to remain in wounds cruel? Were they ignorant? Were they so overwhelmed by the volume of the dying that they simply stopped caring what crawled through the flesh of the ones they could not reach? Some of them, probably yes, but not all of them. Because the ones who left written records were not confused about what they were seeing. They were confused about why it worked. And that is a completely different problem. Noticing a real effect before you have the language or the framework to explain it is not ignorance. It is the first move in every piece of medicine that eventually turned out to be right. The mechanism existed. The larvae were doing something biological and specific and real. It just took another 300 years and a man named William Bear working in a Baltimore hospital in the 1920s to prove what it was. William Bear had seen it in the First World War. 2 soldiers, both with severe compound fractures of the femur, both lying in an open field for 7 days before anyone reached them. both alive when they arrived at the hospital, which by itself was unexpected. When Baer examined their wounds, he found larvae, thousands of them, and underneath the larvae, he found something he had not prepared himself to find: clean, pink, healing tissue. No gangrene, no blood poisoning. After 7 days in a field in France, he did not forget it. He carried that image from the war into his surgical practice at Johns Hopkins, and in 1929, he published the results of treating 21 children with chronic bone infections, osteomyelitis, a condition that had defeated every other approach available to him at the time. He introduced larvae, controlled specific larvae, and the wounds healed. He presented his findings to the American Orthopedic Association, and the medical community did not dismiss him. Some of them started using the method. That is the modern pivot, not a folk remedy surviving on tradition. A Johns Hopkins surgeon in 1929 with 21 documented cases and a mechanism he could begin to describe. Here is the mechanism, and it is worth holding in your body for a moment rather than just reading past it. The larvae Baer used were from a specific fly, Lucilia sericata, the common green bottle fly. These larvae secrete digestive enzymes onto the wound surface. Those enzymes break down necrotic tissue, the dead, rotting material, into liquid. The larvae consume the liquid. What they do not consume, what those enzymes do not touch with any efficiency, is living tissue with an intact blood supply. The chemical signature of dead tissue is different enough from living tissue that the larvae follow the necrotic material and largely leave the viable flesh alone. This is called debridement, the removal of dead tissue to allow healing. Surgeons still do it today with scalpels and irrigation. In Baer's wards, the larvae were doing it continuously, at microscopic scale, in every pocket and angle of a wound that a scalpel could not cleanly reach. Beyond the debridement, the larvae alter the wound environment in ways that reduce the conditions bacteria need to thrive. They raise the pH. They produce compounds that have demonstrated antimicrobial properties against organisms like Staphylococcus aureus and Streptococcus, two of the most dangerous wound pathogens available to a pre-antibiotic physician. None of the ancient practitioners who used this method knew any of that. The Maya did not know about pH. The Aboriginal healers did not have a theory of bacterial inhibition. What they had was the wound that healed and the wound that did not, compared across enough bodies and enough seasons that the pattern held. And here is where you have to be careful, because the mechanism, being real, does not make every version of this safe. The larvae doing useful work in a controlled clinical setting are not the same thing as an unmanaged infestation. There are fly species whose larvae do not select for necrotic tissue. They consume living flesh indiscriminately. Uncontrolled myiasis, larvae reaching a wound from the wrong species or in unmanageable numbers, causes its own destruction. The distinction matters. What ancient practitioners appear to have understood, the ones whose methods survived long enough to be recorded, is that not every wound with larvae in it was the same. Some were better, some were worse. The useful observation was not simply larvae equals good. The useful observation was something more precise than that, even if they could not state the precision in the language we would recognize. This is the part that changes how you read pre-modern medicine. The standard story is that ancient doctors operated on superstition and caused suffering through ignorance. Some did, but the practitioners who noticed that certain larvae in certain wounds produced better outcomes were not reasoning from superstition. They were reasoning from pattern. Outcome first reasoning. The same logic your body runs when it learns a path through a familiar building in the dark. You do not understand the architecture. You understand what works. Pre-modern medicine accumulated enormous amounts of this outcome-first knowledge. Some of it was wrong, built on coincidence or confirmation bias, and it persisted for exactly as long as nothing better came along to dislodge it. But some of it was built on a real material effect that nobody had the conceptual tools to explain yet. Willow bark was used for pain and fever across ancient Greece, ancient Egypt, and indigenous North America before anyone understood salicylate. Honey was packed into wounds for thousands of years before anyone understood its osmotic and hydrogen peroxide properties. Mold contamination was observed to inhibit bacterial growth in various folk traditions before Alexander Fleming made it a controlled experiment in 1928. The mechanism was always there. The knowledge of the mechanism arrived separately, centuries later, and did not change the fact that the effect was real. Maggot therapy belongs in that company, not as a curiosity, not as evidence that the ancients were brave or that history is disgusting, as evidence that careful observation of outcomes, sustained across generations, could isolate a real biological tool without the framework to explain it. Go back to the body in the opening of this. The soldier in the French field with 4 days of exposure and a wound that moved. He did not know any of this. He could not have explained the enzymatic debridement, or the pH shift, or the antimicrobial compounds. He knew his leg hurt and he was alive, and the stretcher bearer had reached him before it was too late to matter. That is the human reality underneath all of this. Not the larvae, the survival, the grinding, improvised, sometimes accidentally correct survival that constitutes the whole of medical history before the 20th century. Medicine did not begin with knowledge. It began with watching bodies, watching outcomes, keeping the things that seemed to work and discarding the things that didn't, slowly, imperfectly, across more generations than you can hold in your head at once. What maggot therapy tells you is not that ancient doctors were ahead of their time. It tells you they were doing exactly what their time required, paying close attention to the thing in front of them, and that sometimes close attention to the thing in front of you is enough to find something real, even if the explanation for why it is real takes another 2,000 years to arrive. The body in front of them was always the same body, the one that heals when given the right conditions, the one you are still living in now.